technical glitch. Hi, Dr. Sachs. Nice to see you, and we welcome all of our participants on this call. We are excited to be here today because today happens to be Giving Tuesday. And what an awesome time to talk about one of our premier programs, the surgical program, when so much is given to people in need through a surgical brigade. So we're excited. We welcome you. And I'm going to just ask some questions. We're just going to have a conversation about your experience with Esperanza and what your brigades are like. And then we'll also entertain any questions we might have, people might have. So I want to start by introducing Dr. Sachs. He's been with us for how many years now, Ray?
10.
10 years. He's been working in the surgical program, surgical brigades. And tell us a little bit about your experience with Esperanza, how you got started, why you stay around. That we love you so much.
And igualmente. So my daughter actually got me involved. She was a newly minted OBGYN in 2009 and was asked to go to Haiti after the big earthquake. And she said, Dad, it's a multi-specialty thing. Come on along. So the opportunity to see my daughter in action was an offer I could not refuse. So I went to Haiti and, incredible experience, as all missions are. And then, that relief effort was over after a year. So my daughter and I decided to go on another mission with a different organization. And we went to Tanzania. And then my daughter started having family and she deserted me and, has actually,
her own thing.
has actually had to focus on her career and her family. So my experience with the first two missions I did was, they were fabulous from a life experience, but not so much from an orthopedic surgical experience. The underlying organization that backed us was not efficient, and we weren't really prepared enough when we went on either mission for me to do what I could do. And so I just did a Google search, and, by fabulous luck, I found Esperanza that was looking for orthopedic surgeons, and I replied, and, 16 missions later, here I am. But what I found in Esperanza was the backing, the organization, the, fabulous people who became my partners in the missions and allowed me to do what I can do and do it in an optimal fashion.
That's wonderful. Well, we have your daughter to thank for planting the bug of surgical missions with you, because we've certainly benefited from that.
Right.
I know that you just completed a mission, the first one for Esperanza in 2 years because of COVID. Can you tell us a little bit about where you went and what you did, how many patients you saw, and how many surgeries you did?
Right. So I just returned from Guayaquil, Ecuador. Guayaquil is one of the 2 largest cities in Ecuador near the coast. It's it's not a city of any great renown. It is sometimes the starting off point for a plane that goes to the Galapagos. But other than that, probably pretty much unknown. In March 2020, I was supposed to go to Guayaquil for the 3rd time. And Esperanza wisely told me that I couldn't go. And 2 weeks later, Guayaquil became the epicenter of COVID in South America, and people were literally dying on the streets. And the cemeteries were full, the mortuaries were full, and they had to rent containers to store all the bodies. So thank God Esperanza was wise, because I was not. I was going to go.
You were going to go anyway, weren't you?
I was going to go anyway. I mean, we were all very confident. Thank God reason prevailed. Anyway, so it's been, so the last time we were there was November 2019. So when we went this time, it was 2 years. since we had gone, and it was pretty much a mob scene of people who needed, not a mob scene. It was a huge number of people who needed to be helped. So does that answer your question where I've been?
It does. And huge mob scene, why, Ray? So these are people who can't get paid, who can't get surgery otherwise. So when missions are canceled, then the list just kind of grows, right, and expands.
Right.
And so that mob scene resulted in you doing how many consultations and then how many surgeries?
Right. So what you said is exactly right. The places where Esperanza goes and the populations they serve are people who, if we don't go, they just don't get served. So the people who are waiting for us in March 2020 were still waiting for us in November of 2021, along with all the new patients new babies that had been born and needed things done to them. So we saw 130 consults, and there was so much surgery to do that there was no way to get it all done. So we did what we could. There was so many very large cases, so many neglected cases that should have been done 2 years earlier. So a lot of the surgery was more difficult than it could have been. And we did 36 cases, but those were all very large cases. So it took a lot of cooperation by our wonderful team to get that much done. And we left about 12 complicated cases behind that we couldn't get to. So for that reason, we're going back in April to see if we can serve all the people.
Nice. And I know we also have a hand mission going there. And you said there were some patients that you could refer for that as well, for specialty type surgical needs.
Right. Yeah, that's a very important thing. Pediatric orthopedic surgeons can do some hands, but the really complicated hand is not really what you're trained to do. And so it was very comforting that the hand cases that we saw that we couldn't take care of, that we could tell them, just come back the first week of April, there'll be somebody here to help you. So yes.
Nice. What kind of surgeries do you do? Like what's the meat and potatoes of what you did?
The most common surgery that we do is club feet. You can go your lifetime in the US, and most of us have never even seen a clubfoot. It's a problem with male babies predominantly. And when we see a clubfoot at birth, literally as the child comes out, when we see a clubfoot, we immediately correct the deformity, put it in a cast. We change the cast every week, and slowly but surely we bring the foot into line. And by 3 months post-birth, that child's normal, and that's all there is to it. So it's a very easy problem to correct at birth if you have people who recognize the problem, who are trained to know how to do the technique to correct it, and who have, good enough materials like plaster, literally good enough plaster, that they can do the appropriate job. None of those things are available in Guayaquil. And for that reason, we see tons of club feet every year. The second thing we see a lot of is firstborn female babies have a tendency to be born with subluxed or dislocated hips. And again, it's not something you can visually see, of course, but in America, everybody gets an orthopedic exam at birth, and it's very easy to discover. And if it's discovered, you just pop the hip in, put them in a cast, and again, after 3 months, the problem is solved. But if you don't recognize it, it's not visual. So the first you know that there's something wrong with your child is when they try and walk and they start waddling and limping. And by then, by a year, when the child is walking, you can no longer pop the hip back in and put them in a cast. So now it needs surgery. So that's probably the second most common thing we do, is operate on young female 1-year-olds or 2-year-olds that were born with dislocated or partially dislocated hips. The third thing that we do a lot of is operate on kids who have cerebral palsy. There are a lot of difficult births and home births in developing countries. And cerebral palsy is what you get when you have a deficiency of oxygen to the brain during the birth process. There's unfortunately a fair amount of that. This leads to kids with a lot of joint contractures, and we're able to relieve those. So that's the third most common thing. And the fourth most common thing is just a basket of congenital deformities, just things that kids are born with. In Ecuador, for some reason, it's really common to be born with a sixth finger or a sixth toe. And of course, a sixth finger, it's usually a thumb. It just sticks out and is, very noticeable. And you can't let a kid go to school like that. They'll get teased. And the sixth toe actually just makes the foot too wide to fit in a shoe. So it's not maybe the worst thing in the world. It's pretty easy to correct, but it's very important.
Wow, every time you go and you and I have a chance to chat, and I learn more about the situations, and didn't know how cerebral palsy was caused. So I learned something new. I'm sure our participants are learning that as well. I do want to take one question. One of our participants is asking if you had trouble getting blood.
No, they do have a blood bank. And I think one of the things that Esperanza does, which is not your direct job, Jerry, so you might not know it, is position us in a hospital that has that's good enough that it has the necessary safeguards in it should we get in trouble. We usually go through an entire mission without needing any blood, but the hospital does have a blood bank should it be required.
Yeah, you bring up an interesting point, because in Ecuador, we partner directly with the Children's Hospital, and that Children's Hospital does almost exclusively surgical missions. And so we feel very blessed. They're not unusual, but somewhat better equipped than a lot of our other partnering hospitals that we visit. And that makes the missions go a lot smoother. Was there anything in particular you were concerned about in going on this mission? Did you have any concerns about it, or cause you to prepare any differently?
Yes, I had quite a bit more anxiety before this mission than I usually do. And that was because I knew there was 2 years worth of patients waiting for it. I knew that a fair amount of the patients were neglected and their problems would be difficult. We did get a partial, one of the wonderful things that happens is after the screening clinics take place in Guayaquil, they'll literally send us a list and quite a few x-rays of the patients that they've screened for us, which allows us to prepare. And, sort of the horror of looking through these x-rays and looking at all these kids that should have been done a year or two ago, and now were much more deformed than they should have been, knowing that you had lots of surgery and lots of tough surgery ahead of you, caused me anxiety. But it also resulted in the team putting their heads together and really collaborating incredibly well on how we were going to get the work done. So it was what could have been a bad thing turned into a good thing.
Because 35 surgeries, that 36, that's a lot for an orthopedic mission, isn't it?
Yes.
Yeah, that's a good number. So you spoke a little bit, you already spoke about some of the differences, sort of why these cases come up in international or other countries and not so much here, which speaks to the difference in healthcare. Can you talk a little bit about what you see as the big differences or gaps between the healthcare in a country like Ecuador and a country like the US?
Right. Well, there isn't health equity. The US lacks a lot of health equity, but it's just ubiquitous in developing nations. If you have money, if you're a politician, you can get reasonable care. But there's some things that you just can't get. In Ecuador, where people are just as smart as we are, the doctors just don't have access to good training. Their medical programs and their specialty training programs are so substandard that they just don't learn how to do the things that we learn how to do in our specialty training. So first of all, there's nobody outside of the big city, the few doctors that have had a chance to maybe go to Argentina or Brazil or Cuba or the US or someplace where they've been able to get good training. Other than that, unless you're in some big hospital in a big city where you have access to that, if you're anyplace else, you just don't have people to know how to do what you do. Secondly, they don't have the equipment. Orthopedic surgery requires a ton of equipment. It's very expensive. They don't have the money to buy it. Even simple things like plaster is so poor compared with, what you get when you're putting a plaster cast in the US, that it doesn't stand up. The patients go home and 2 hours later, the cast is wrecked. So they don't have that either. So there's so many things that they lack, not out of goodwill, not out of trying, not out of caring, not out of intelligence, but they just don't get it. They just don't have it. So you feel that when you go there. You know when you go there that if you don't take care of the patients in front of you, they're just simply not going to get taken care of. Not now, not next year, not ever. So yeah, so that's what makes missions so special, really.
Right, and it's interesting you talk about having the training and the education and the equipment, because I don't know if you saw our post today, many of our listeners might have, that we have a team in Nicaragua, people that you're very familiar with, led by Luis, doing surgical missions as we speak at a hospital there. And the hospital ran out of gauze. Can you imagine a worse nightmare for a surgeon not having gauze? So they were making sort of makeshift pads and things that they could sterilize and put together to continue to serve patients. But that's exactly what you just spoke to.
Yeah, and this really kind of speaks to the importance of donors. If I could just segue for a second.
Please do.
Okay.
Because that was my next question. How can we help? How can people on the call get involved and help in this effort?
Right. So after you've been doing this a while, you quickly realize that you have to bring everything. That they're going to run out of things, or they're not going to have what you need. So in order to do an efficient mission, you need to bring everything. So on this past mission, we brought 400 pounds of supplies. Now, yeah, so imagine the money it takes to buy 400 pounds of orthopedic supplies, right?
Right. Well, tell us about how much.
Oh, well, several $100,000.
Yeah. Okay. Yeah. It's a big number. Unlike other surgical missions, this is a particularly big number.
Right. So the equipment that's metal, like drills and saws and implants, some of it is reusable. So it's not like you have to spend all that money every mission. But the consumables, starting with the simple thing like gauze, but everything you need to bandage a patient, cast a patient, sew up a patient, every single thing you can think of that you consume in patient, plus all the anesthesia drugs, the anesthesia supplies, the needles, the tubes, everything, all the consumables, you need to bring that. And you need to buy it. Somebody needs to buy it. And there's probably no one person who can really do all that. And so, I mean, I know particularly in my case, if I didn't have donors supporting me, I just wouldn't be able to do it. So, I mean, that's where donors come in. So, I mean, it's down to a science with Esperanza. The surgeons, everybody on the medical team pays for their own airfare, they pay for their own hotel, they pay for their own food. The hospital donates a great deal of, patient days and the beds and everything like that.
Services.
So all the money that's donated literally goes into the mission. It's not going to pay for some doctor who wants his flight for free or anything like that. It's all goes into equipment and supplies. It literally goes into what it takes to operate on a patient. And because everybody volunteers their services, an operation like a clubfoot operation, which in the US might cost anywhere between $20,000 and $40,000, we do for somewhere between $120 and $150. So there's hardly any place where you can donate your money, where you can get that kind of impact. And I think that's one of the things that makes working with Esperanza very special for me.
That's great. So we can help, those of us listening can help by donating funds. It helps us pay for the supplies that we need to deliver the surgeries. As we're kind of winding up, I just want to remind everybody that if you have a question, you can put it in the chat. And I guess my final question, Ray, because you've been doing this for so long, and I know you have a lot of stories, but I wonder if you could share with us one of your most memorable stories from one of your missions.
Oh, well, I mean, there are so many, but a couple of years ago, as you know, you remember when we were in, I think it was Peru, wasn't it, Jerry, that we operated on this gal with cerebral palsy.
Yes.
And she was, I think, 13 years old or 15 years old, and her mother had carried her on her back her whole life. And after we operated on her, she walked for the first time. And her parents, who lived in the mountains, built her these parallel bars out of wood so that she could practice at home. It was really quite a heartwarming story. So that's certainly one that stands out, but there are so many.
Yes, I understand the mission. One of the brigades or missions that I've been on was the ophthalmology. And I think, as you know, because you see it firsthand, what I saw is how many people are impacted by one person getting a surgery, right? The families, the parents, the system, the people that support that person, or in some cases, the breadwinner of the family, and I found that it is about one surgery at a time, but it has such a wide, so many ripples.
It does, just to emphasize that, in developing countries, there's high unemployment rate. And if you're not in good physical health, nobody has a reason to employ you. I mean, there's no reason to hire the handicapped. There's just, there really is no such thing like we talk about. So it's hard enough to get a job if you're fully functional. It's really hard to get a job if you're not. And if you don't have a job, nobody wants to marry their daughter to you, or no daughter wants to marry their son to you, or I'm sorry, no family, So,
yes.
So if you have a deformity, you are probably not going to get married. You are probably not going to have a job. You are probably going to live with your parents your entire life. So the consequence of having a disability in a developing country is so expansive as compared with the US.
And there's a lot more stigma behind it too, yes. Isn't there?
Yes.
So it would be fair to say that the surgical missions, let's just speak about the ones that you do, in addition to all the others that we do, really change the trajectory of somebody's life. Those children that you operate on are going to be functional, healthy, wage-earning adults, where right. They might otherwise not be.
That is the goal. Right.
And boy, I don't know about all of you listening, but I am so grateful to you, Dr. Sachs, for your work with Esperanza and for the work that you do. and we hope to get you back to Nicaragua real soon. I know that's a big desire. But anyway, I just, on behalf of everybody on the call and all of us here at Esperanza and all of our donors, thank you. Thank you. It is a labor of love that you do and your teams do. And we're grateful for you.
And I am equally grateful for you, Jerry, and for everybody at Esperanza. It's a team effort for sure. Neither one of us.
It sure is.
Yeah.
It takes a village for sure, right? To do this work.
Yes.
So you're getting lots of good messages. Thank you for all you do. Thanks for being on the call. So thank you, Dr. Sachs. I'm going to end our session together, and I look forward to seeing you soon again in Phoenix, or maybe I'll have to come to San Diego.
You are welcome.
Thank you. Take care, everybody.